Hello everyone, welcome. It's lovely to see you here on such a lovely sunny evening. This is our very first mental health in focus event, and we're going to use it as a pilot, but also to make sure that we send messages about all of the great work that's happening in Norfolk and Suffolk Foundation Trust in terms of keeping our communities safe. And tonight, we're going to be looking at this amazing project called Stepping Back Safely, which is going to talk through all the things that are being done to manage the risk of suicide, and also to provide carers the tools that they need in order to support the people they care for, while also looking after themselves. So I'm Zoe Billingham, I'm chair of NSFT, and I'm really happy to introduce Stuart Richardson, who's the chief executive, who's now going to introduce our excellent presenters who are going to talk us through this brilliant project. And there's going to be time at the end of the presentation for a Q&A session. So over to you, Stuart.
Thank you, Zoe. Good evening, everybody. I'm Stuart Richardson. I'm the Chief Executive here at NSFT. Yes, thank you very much for joining us this evening. It's really good that you can be here. I'm going to hand over to Catherine and Deirdre in a moment, who are going to talk through the Stepping Back Safely project for us. If you've got any questions or you've got any comments, pop them into the chat box and we'll come to them at the end of the presentation. We can also answer any other questions you may have this evening as well. So anything you want to ask Zoe or myself, please feel free, pop the question into the chat box and we'll get to them in a few moments. So not to delay, let's hand over to Catherine and Deirdre, who are going to talk through the presentation with us. Evening both. Good to see you.
Thank you, Stuart. So I'll just put the presentation up and then we can get started. Hold on. Hi, yeah, so I'll introduce us first. I'm Deirdre Williams. I'm a clinical psychologist and I work across 3 community mental health teams in Norwich. And I've been working with Catherine on the Stepping Back Safely project for a year. We've been funded by the Trust to develop this project, which is all about working with carers and service users to reduce the risk of suicide and self-harm. I'll let Catherine introduce herself now. Catherine?
Apologies, everybody, I got stuck on the mic. My name's Catherine Phillips. I've worked for NSFT for about over 6 years now. I'm a carers lead within the Trust, and I'm a trainer also within the Trust. And I've been working with Deirdre on this project as well.
So what we're going to do is we're going to really briefly describe our project, and then we're going to introduce some of the ideas that we've felt have been very effective with carers and service users, and also that they've responded to and really identified with as well. So just to introduce you some of the concepts that we're using in our project. So in terms of the origins of our project, it originally came out of focus groups that Catherine and I ran with service users and carers in Great Yarmouth and Waveney around suicide risk and how they wanted to be helped, and how they wanted to be helped and responded to by the Trust. So we used those focus groups to develop the ideas behind the project. We were also guided by national research, which suggested that carer involvement could potentially reduce suicide. And we were looking at our own lessons learned. So every time we have a patient death, we have a serious incident report. So there were some local audits of those, and a strong pointer to the idea that involving family and carers more closely and more effectively might help prevent suicide. So we were guided by those 3 things when we came up with our project. And I'll talk to the first bit of this, which is there are 3 elements of our project. We've got a 4-session safety planning intervention. We've got a workshop for carers, and we've got training for staff as well. I'm going to talk about the safety planning intervention briefly, and then I'm going to hand over to Catherine to talk about the carers workshop. So the safety planning intervention is a 4-session therapeutic intervention where we try and get the service user and the carer to meet with us and develop a really in detail safety plan for the service user over a number of sessions. It's guided by a workbook, which the service user and carer can look at between sessions and collect their own ideas about what might work. And we really brainstorm about any difficulties that the service user has had in the past, what's led to crises in the past, and try and put in appropriate skills and techniques to help them manage their distress when it shows up again. So it's based on there's a lot of research suggesting that safety planning is an effective intervention to prevent suicide risk, and there are American versions of safety planning, but our version is a little bit different in that it's the only version of safety planning that we know of that explicitly involves the carer. It's very recovery oriented, so in addition to helping people manage their distress, we're trying to get them to build up their lives again, to get things into their lives which give their lives meaning and value. We also borrow from a therapy called dialectical behaviour therapy, and from a model of trauma, which we're going to present to you later, because it's one of the models that service users and carers have really latched onto and found very useful. So it's the only current model of safety planning that uses those three elements there. And I'll hand over to Catherine now to talk about the workshop for carers.
Thank you, Deirdre. Just before I talk about the workshop, I just wanted to say that our project is very much underpinned by the Triangle of Care, which you may already know that is a national initiative that was launched by the Carers Trust in 2010. The Triangle of Care describes the therapeutic relationship between the patient, staff member and the carer, and it promotes safety, supports communication and sustains well-being. And we as a trust joined the Triangle of Care in 2014. We got our award for our awards, and my colleagues and other carer leads and all our colleagues across the trust worked very hard, and by 2018 we were given the Triangle of Care Award for our community teams as well. So we really wanted to encompass the Triangle of Care and help it to underpin the project. And we feel that not only the safety planning intervention, but the carers workshop really does demonstrate the Triangle of Care in action. So we, really trying to aim to provide a much more joined up approach for everybody, carers, staff and service users. And we're also trying to reduce the carers' experience of feeling excluded or alienated from services. So when we were looking to develop the carers workshop, we were lucky, very lucky, to be given the opportunity to work with a group of 10 carers. A number of those carers had very sadly lost a loved one to suicide themselves, a member of their close family. And the other carers within that group have all been caring for people who have attempted suicide in the past and who self-harm on quite a regular basis. So they're a wonderful group of people who have a really tremendous experience, lots of experience of both lived and learned, and they really helped us to develop the carers workshop. We spent 3 months developing it. We worked through during the days, evenings, weekends, whatever time they had available. They all had their own jobs and other commitments, but they stayed with us. They were really keen to be involved. It was a piece of work that they felt really personal feelings about, and they really wanted it to come to life. So they did. We developed the workshop, and we have now been running it since February of this year. And there is a group of four of the core group of the working group are still staying alongside us to co-deliver that workshop as well. So I think it's a really valuable resource. It's a valuable tool. It's very much a psychoeducation workshop for carers. We deliver it at weekends or in evenings, and the first part of the workshop really helps the carer to understand what's happening to the service user when they're in that suicidal state of mind. And then the second part of the workshop is very much around the carer, their needs as well, and looking at what tools they can use to help themselves reduce burnout, and to also help them to stay within their window of tolerance. So I'm going to pass back to Deirdre, who's going to talk a little bit more about the staff training that we're delivering as well. And then she'll talk about the window of tolerance a little bit more.
Yeah, so we're now at a stage where we've run these interventions and workshops ourselves many times, and we're training other staff to provide them. So we run training for staff on how to deliver the safety planning intervention, and we're preparing training for staff on how to deliver the workshop for carers as well. So we're hoping to be able to roll this out more widely across the trust where it's needed. We've had really good responses from staff about the training that we've provided. They found it helpful, and also very good feedback from carers about how useful it is, not just the content of the workshop actually, but how nice it is to meet other people in their situation who can empathise with their position. So we've had really positive feedback about the project so far, which has been very motivating. Yeah, I'm going to move on to discussing some of the elements that our carers in particular maybe really respond to. But I mentioned that we use a model of trauma. It's called the window of tolerance, and it's a model of emotional regulation, really. And so I'll just talk you through that. So the window of tolerance is a range of emotions where we feel cool, calm, and collected. It's within this window of tolerance, we might have strong feelings, but we can think clearly, we can observe ourselves, we can connect to other people. If our emotional arousal level gets too high, and this happens to all human beings at times, we become hyper aroused, hyperactivated, too much emotion. And in that state of mind, we can feel highly impulsive and reactive. We're unable to think of consequences. We might feel compelled to act or get rid of an emotion or escape from the situation. And many of our service users, when they feel like doing something harmful to themselves, are in this state of mind. They're very, very strong emotions, feeling impulsive, unable to think about consequences, and having very strong action urges. And then there's another state of mind which maybe initially seems safer, but is actually quite dangerous too, and that's when you've got too little emotion. So when you're too little emotion, you're often quite shut down, you're cut off, you might have withdrawn significantly from social relationships and from the world. You might feel numb. And in this state of mind, you could find yourself ruminating about negative thoughts, just chewing over the same hopeless thoughts repeatedly. And within this state of mind, it's really hard to shift your attention away from those thoughts as well. So you're just churning negative thoughts. Both states of mind can be difficult for people. Both states of mind can be associated with suicidal and self-harming behaviour. And some of our service users say that they mainly act on impulse and they're in that hyperactivated state. Some say that when they want to do harmful things to themselves, they're in that hyper-aroused, cut-off position. And some say that they find themselves oscillating between the two states of mind. The other thing about the window of tolerance is that our window of tolerance can become really narrow if we've experienced recent trauma or stresses. All of our window of tolerances, I think, became a bit narrower during the COVID-19 epidemic and lockdown, when we lost the activities and the connections that normally keep us well and keep us resilient. And for many of our service users, if they've been suffering with low mood or suicidal urges for a long time, you'll find that a lot of their activities, a lot of their connections have kind of dropped out. Their lives have become much reduced. And as a result, their resilience has become less. Their window of tolerance can actually be really, really narrow. It's shrunk. So when we're working with the service user, we're trying to give them skills to reduce their hyperarousal, nudge them back into their window of tolerance. Or if it's the hypo-aroused state, the deactivated cut-off state that's problematic for them, we're trying to give them some skills to nudge them back up into their window of tolerance and get them active again, get them connected again. And we're also encouraging them to connect or reconnect with people, activities, connections, communities that give them that resilience and can expand their window of tolerance. And initially, we just started off applying this model, which applies to all human beings, actually, but to service users experiencing difficult, risky states of mind. But as soon as we did, I think we found that carers also could relate to it. And I'm going to hand over to Catherine to talk about the carer experience there.
Thank you, Deirdre. So yes, when we introduced the window of tolerance model to carers, we found very quickly that they really connected with this model themselves. And they can often be just a little bit behind the service user when they are coming outside of their window of tolerance. And very often carers have experienced traumatic events. They may have to respond to somebody who has taken an overdose, has harmed themselves, take them to A&E. And that can be very distressing for the carer. So when in those times, the carer will often recognize that they are in that hyper-aroused zone, feeling quite impulsive and needing to take action. But also what we've recognized with all of our work with carers is that carers can also be in the hypo-aroused zone, feeling cut off. This is especially when carers are feeling very burned out and they have gone through a really significant cycle of crisis and risk and having to manage that risk. And at those periods of time, it can be really difficult for the carer. So again, like Deirdre said, we are trying to teach carers skills and tools to help them stay within their window of tolerance. And what we do, particularly in the carers workshop, is we try to explain how the carer can expand their window of tolerance to try and maintain and manage while the service user's window of tolerance is narrowing. And there are some key skills that can help with that as well. So for a carer who's feeling really burned out, it's around trying to help that person to put maybe more into their lives, because very often carers will have given up work, lost all their connections with people, with their community, particularly when they're supporting somebody with high risk. They often feel that they need to be there 24/7, and of course that will lead to burnout. It's normal, it's human. So trying to help carers to put things back into their lives, to increase their connections with other people, their communities, with spiritualism, you know, with those things that can give them meaning and purpose, doesn't mean to say that that's going to stop them from doing their caring role, but it will enhance them and it will feed them as well. And for the hyper-arousal zone, we're trying to help upskill carers to understand what's happening in those moments, in those really risky moments, and how they can respond better for people. And we do that within the Stepping Back Safely carers course. And also we do it when they are party and part of the safety planning intervention as well.
Thanks, Catherine. So this concept has gone down really well with service users and carers, and I think another thing that it explains to carers sometimes is why the person that they care for can feel quite unreachable when they're in these two extreme states. So when you're hypo-aroused, you don't really feel that connection with people, you don't feel the kind of love and support that might be around you. When you're hyper aroused, you can't really take anything in. You know, you're just so overwhelmed, you can't take anything in. So I think carers feel less rejected, understanding that when their loved one is in these extreme states of mind, they can't connect. It's not their fault. They're not deliberately rejecting the carer. It's just, it's very difficult for them to connect. So they have to help them back into the window of tolerance before that connection can be re-established. We'll move on to the next slide. So another idea that we introduced, we stay on it briefly, but it does have quite an impact on people, is the idea of putting on your own oxygen mask before helping those around you. So we've all seen these safety videos and demonstrations on aeroplanes where they encourage a parent to put the oxygen mask on first so that they can breathe before they put the mask on the child. And I don't know how many of us would be able to manage that in an emergency situation. However, it's akin to what a carer needs to do when a service user is in a highly distressed, highly risky state of mind. Is actually they need to find the skills to get themselves back into the window of tolerance so that they can respond helpfully, not in a reactive way or overreactive way, not in a cut-off way, but they can respond helpfully to that person. We feel that this image, we show it in different forms, is a really good lever to help the carer in that moment, just for an instant, put themselves first and ground themselves and just stop. And we teach them some skills to kind of stop and take a step back at that moment so that they can then respond in a more considered and less reactive way to the situation that they find themselves in. And again, they found this idea quite helpful. And the last idea that we want to present, I think, is about the triangle of care again. So we know that when the service user is very distressed, so long as the staff member, the professionals, the service remains in their window of tolerance and the carer remains in the window of tolerance, we won't be escalating that service user's distress. But if everybody comes out of their window of tolerance, what we see is that triangle of care actually morphs into something else. We've seen it morph into a triangle of helplessness, where everyone feels helpless and disempowered and doesn't know how to help. We've seen it morph into a triangle of blame, which again is understandable when we're feeling very overwhelmed. We can become quite critical of those around us, but to keep ourselves in the triangle of care. So it's kind of a reminder to staff that they need to get into their window of tolerance before they respond, and the carer does as well. And then we can have a nice regulated triangle of care around the service users' distress and risk. And that will hopefully mean that the service user can be soothed and brought back into their window of tolerance and can maintain the connection with others and can maintain that kind of collaborative working together rather than the triangle falling apart. So this is the kind of model that we're encouraging staff to think about and carers to think about as well. Okay. So in terms of what we provide carers, so within our safety planning intervention, we teach mainly the service user some new skills, but the carers obviously learn about some of those skills too. But with a more explicit focus on carers within our carers workshop, we're trying to do 4 things. We're trying to help them build skills, so using skills to get themselves back into their window of tolerance, building skills to help get their loved one back into their window of tolerance as well, to build confidence, to improve their confidence about how to respond to their loved one. So often it's just being able to validate to the carer that they're doing things right. We often find that people are responding in a really caring, empathic, non-reactive way, and actually, but they just need some help kind of having confidence in what they're doing quite instinctively. We're encouraging them to enhance their self-care. So for those carers who have reduced their own activities, work or connections, we're trying to encourage re-engagement with valued activities and relationships in order to improve their resilience. As Catherine said, we want them to expand their window of tolerance as well. And sometimes we need to think about resetting relationships. So when people are in highly stressful situations, sometimes ways of responding evolve without anyone thinking about it too much, which either have a negative impact on the service user or the carer or both. So it's a chance, particularly in our safety planning intervention, for carers and service users to think, is this working and what can we be doing differently? And within our carers workshop, we get carers to think about their supporting style and the pros and cons of those supporting style, and actually how they might want to modify their supporting style, either to better help the person that they care for, or to actually be able to make themselves more resilient as well if they're in danger of burning out in particular. So we get them to put a reset on certain relationships in those interventions. So I think we've presented what we wanted to present from what we've done. We've tried to do it as briefly as possible so that we can leave some time for questions. Before we move on to questions, Catherine, did you have anything you wanted to add to that latterly, or?
No, I think you've covered it all, Deirdre.
Okay, so I'll take the presentation down and we can be open to questions now.
Lovely. Deirdre, Catherine, thank you both very much. Thank you for everything that you've been doing. A fantastic project. It's been really good to hear about it. So absolutely, we're open to questions. You can ask us anything you like this evening, and we're recording as well our conversations tonight, which means that many of our colleagues who are not able to join us will be able to watch this back at a later date. So please pop your questions through to us, and we'll get through as many as we can. I think it's also important at this point we mentioned that if you do know of anybody who is distressed, or if you do know of anybody who is in a situation where they need help, we are available 24 hours, 7 days a week by calling 111 and pressing option 2. You can get straight through to our crisis team, and there will always be somebody there to speak to you. Okay, so Deirdre, Catherine, some questions for you. A question here. Such a great project, absolutely. How many people have you helped with this so far?
I suppose we're not entirely clear at the moment. We have, I suppose we've done about 20 safety plans with people, but we've also trained people to provide safety plans. So that's the bit that we don't know how many of those are now being provided yet, but we are hoping to find a way of supporting safety planning, perhaps by providing supervision, so we can have a better idea of where this, also for us to know where this approach is really taking hold, because in some settings it's easier to deliver than others, and also who it's reaching. So at the moment we're trying to reach those service users who present with the most risk. So we've prioritised those. In terms of carers, we ran 6 or 7 carers workshops when we were working only in Yarmouth and Waveney, and we've run the new workshop, the new co-developed, co-facilitated workshop. It'll be 3 times on Saturday, won't it, that we've run the workshops, but we're hoping to make those available to any carer for any service user in the trust who finds themselves in this situation. It's spreading by word of mouth, and we've had, again, very, very positive feedback from the carers on that. So it hasn't reached a huge number of people, but we have seen a big impact already, and hopefully it's shifting the culture a bit as well, I think. So I think the second question was about why isn't it obvious to involve carers, and we agree, why isn't it obvious to involve carers, but the published versions of safety planning don't include it. There's a UK multi-site randomised controlled trial going on at the moment, which doesn't include carer involvement, I don't think, either. So, you know, it seems obvious to me. It seems really obvious to Catherine from her vantage point of being a carer's lead. But yeah, it's unusual that there is that gap in the research literature, really, because we found it to be so much more effective to do this intervention with the carer there in the room and everybody there, everybody working together, than to work with just a service user in isolation. It does seem really obvious. We agree. Sometimes doing the obvious is what's needed, though.
It absolutely did, absolutely. And we hear, don't we, quite often from people and families that they don't always feel that they have been involved. What do you think the barriers are to stop people from involving the wider family, and why they perhaps don't do what you described there as being the obvious?
Oh, that is a big question. I'm trying to think. So, I mean, sometimes a service user will not consent to the family member being involved, and that can be an obstacle. But again, it's an obstacle that we try and work with. We try to sell to the service user the idea that it's nearly always beneficial to involve the carer, and if the reason they don't want the carer to be involved is because of something around the supporting style being perceived by the service user as unhelpful, we will say to the service user, this is a chance to renegotiate that. That's something that we're confident we can help you with. I think staff are busy, as we know. I think that it is a cultural shift that people need to make. I think we have worked in a very medical model, which is treating the individual and the disease. And this is a different way of working. This is like thinking about the person in their context, the person in their family, the person in society. You know, it's a different way of thinking about it. So I think maybe it's we haven't moved far enough away from the medical model for that to be obvious yet, even though it does seem obvious to carers, it seems obvious to lots of people that we should be doing this. When we initially did focus groups with carers and with service users, we also did some focus groups with staff, and I think that they were sometimes a bit afraid of involving carers as well. They didn't feel they had the skills to deal with family situations in the room, and we're hoping that the training does help staff to feel, actually, you know what, I can do this. It's just, you know, we teach some validation skills, we teach some skills for everyone to assert themselves and get their needs met, so we help staff feel they've got the confidence to deal with potentially difficult interactions, either directed at them or in the service user caring relationship. So I think it's a confidence thing for staff, but it's not something that people get trained on when they do their nursing degree. And I did a psychology degree, obviously, in a clinical psychology training, and we had very little family work for preparing us to work with adults of working age. Anyway, we had hardly anything. So I think there's a cultural shift that needs to happen with training as well, so that becomes more the norm.
Thank you,
Can I just add just a little something to that as well, and that you know, sometimes it's really hard to reach the carer at the right time in the right place, and so we're doing a lot of promotion about what we're doing. We're advertising the workshops with our stakeholders, with Norfolk, Suffolk VASP, Great Yarmouth and Waveney VASP, and with Norfolk County Council as well. And we're actually doing the workshops in evenings and weekends, particularly to accommodate carers who are working as well. So we often see carers at that point of crisis. So what we're trying to do is work with our crisis teams, our mental health liaison teams, and our community teams to ask them to look at their caseloads and identify those people who we can try and reach out to and connect with without breaching anybody's confidentiality in any way whatsoever.
Thank you, Catherine. Thank you. The next question is around the current arrangement that the Trust has, that we have with Samaritans, with people. Catherine, do either of you know enough about that arrangement to answer that question, or is that one that we'll follow up afterwards?
Yeah, that's not something I could speak to, I don't think.
Okay, it's a good question though, isn't it? So whoever's posted that question, we'll make sure we post a reply for you on the website to make sure that we can give you some of the numbers of the people who are involved in that, but most importantly, we'll put forward your points to the people who are overseeing that for us. Okay.
Just as an add-on to that, Stuart, Papyrus is an organisation. It's a national charitable organisation, and they do a lot of work with the carers of people who are of younger age. So I will give you the details of that to forward on as well.
That's fantastic, Catherine. Thank you. The next question, how is this work affected if the service user is experiencing psychosis? Who'd like to take that one?
Okay, I can talk about it with the safety planning. We have had people with diagnosis of psychosis come in. It's usually been between episodes or when their symptoms are being fairly well managed, but certainly We know a trigger to self-harm can be voices, delusional ideas and things like that. So we would treat that just like we would treat anybody else. That's the internal experience that they have, which causes the urge to do something harmful to themselves. If someone was really floridly psychotic, that's a kind of technical, old-fashioned term, but if someone's really, really very unwell, it wouldn't be a good time to do this intervention. The person has to consent to the intervention. They also have to have capacity to consent to the intervention. So before we meet with the service user to offer the intervention, we'll be asking, we'll be informing them about the intervention, saying this is what it is. Is this something you'd like to give a go? Is this something you'd be interested in? So we get their consent, and actually, but sometimes people are too ill to consent at that time, so we wouldn't be offering it to someone who is very, very unwell at that time. But we don't exclude anybody on the basis of their diagnosis.
Okay, thank you very much. A really nice comment there from Sue. Thank you, Sue, for watching this evening, but also for your comment. Not a question, but a comment. One of the most comforting and calming things that has happened to me is that when in an A&E department with my cared for and in crisis was when one of the liaison team took me aside, put a hand on my shoulder and very caringly asked me how I was. It made such a difference to me in that moment and will stay with me always. That's an example, isn't it, of what really makes a difference to people. Catherine, Deirdre, I'm sure you hear this from carers and from people when you're doing your training session.
Yeah. I mean, carers just want to be heard and listened to. They often feel unconfident or unsure about what they're doing, and often want us to tell them that they're doing it all right, they're doing the best they can. And I think that's one of the key things that carers come back to us on, saying that their confidence has increased, their capacity to understand what's happening to their loved one at that point in time has increased. They're more engaged with the person, and they just feel that they can, they're equipped better with tools to be able to do what they need to do. I mean, we're not asking carers to hold it all. We're not asking them to hold everything. We're just trying to support them and give them the tools that they need to feel more confident, secure, and safe.
Thank you, Catherine. We've popped into the chat there the link through to Papyrus, so that's handy if you want to just click on there and have a look. We're closing questions very shortly, but we'll keep going for the next few moments. Deirdre, Catherine, are there any plans to expand this work to cover any other sorts of risk?
There are forms of safety planning available for all kinds of risk, actually, for domestic violence, for victims and perpetrators of domestic violence, and for all kinds of risk. But at the moment, our original project was paid for by national suicide prevention money, and then has been funded by the board specifically around trying to get more involvement for carers in this kind of work, more support for carers when their loved one is at risk. So we haven't got any plans to expand it to cover other sorts of risk, but safety planning as a thing is available to cover other sorts of risk.
Lovely, thank you. Thank you.
And we do provide safety planning training for all members of staff. Yeah. Fantastic.
Catherine, Deirdre, we're going to give you a rest for a moment. We've got a question there for you, Zoe. How are you finding the trust? Good question. And I've seen you on board before and I like your style. Really interested to hear what staff are saying to you as well.
Thank you very much for that question. That was a little bit unexpected, I must admit, but that's the beauty of these wonderful sessions. First of all, I'd just like to say a massive thank you to Deirdre and Catherine. I've learned so much today. I'm still in that kind of massive learning phase and everything is really new to me. Thank you so much for your question. I think the trust is extraordinary. I think we do amazing things and do incredible work to keep people safe, and I think we're pushing the boundaries of the art of the possible. And I think what we've heard today from Deirdre and Catherine around this care and support for carers is so vital. I also think that as a trust, we've got enormous challenges ahead, but I feel incredibly confident that the people that we have working within the trust are up for these challenges, and we will meet them. And what I love, like today's event, is the innovation that we see day in, day out, and the frankness and honesty with which we approach the quest that we're on, which is to enable our communities and those with mental health needs to lead their best possible life. The dedication is extraordinary. So what staff are saying to me, it's really tough. There's an awful lot that they'd like to do more of. They'd love to have many more hours in the day to be able to do more of the care, more of the innovation, more of the kind of basic provision and protection that they're able to provide. And it's our job as the leaders of the trust to ensure that our staff are able to do the best possible job, to equip them and to enable them to do that job. So I'd like to ask a question actually of Deirdre and Catherine, if I may. This issue around carers is personally really, really close to my heart from my own kind of personal and lived experience. And one of the things I puzzle coming in from outside to the NHS and to mental health is why the default position isn't that in each and every single circumstance we will involve carers in the care planning alongside our service users. I'm particularly taken aback by some of the people who've reached out to me who have found it really difficult as individuals, as mums in particular, and that's not being gender specific, but it has been mums that have reached out to me because they're desperate, because their children have not wanted them to be engaged in that care, and they say to me things like, but I know that individual so well, I know what they're like when they're well, I have so much to add to the kind of the backdrop and the story that will help us as a trust provide the best care. And I find it utterly heartbreaking that that for some reason the law is such that there's often not a way in for those folk. And I hear what you say, Deirdre, about your approach, which is to work towards a position where you can involve the carer, and that's great. But I'm just baffled why we're not starting maybe as a country from the starting point that it always has to be good to involve that individual's loved ones in their care. I know there has to be exceptions, but the starting point should be let's involve rather than, you know, let's look to see if we can involve.
So what I would say, Zoe, is that that's one of the main reasons that the Triangle of Care was set up as that national initiative back in 2010. It was very much parents of children who had reached the age of 18 and had come in, you know, reached that adult age where confidentiality is that cut off. And what I've delivered not just this safety planning intervention, but I deliver safety planning intervention for the whole of the trust alongside Dialogue Plus. And what I've said to staff is the one thing I've asked staff is to think about how they ask the question. So really think about how they ask the question, when they ask the question of the service user, and how that can then influence the service user to allow their carer, their family member, their friend to come on board and give us that really valuable information that sometimes people do forget to give us. Not purposefully, but sometimes it can get lost in translation. So I say to staff, consider how you ask the question, because if it can make a difference to that person's life, if it can keep them with us, if it can keep them safe, then that's truly what we're trying to do.
Thank you, Catherine. Thank you. I'm going to give last word this evening to Sue. Sue's message here to say, I've done the carers workshop and I've been involved in the project and can say without a doubt it's one of the most useful and helpful training things I've done in my role as a carer. Thank you, Sue, and thank you, Catherine. Thank you,
Sue.
Catherine, Deirdre, if people want to find out more information, how is the best way that they can contact you?
We have an email address. It's steppingbacksafely@nsft.nhs.uk. Anybody can contact us on that email address, and that is managed every day.
Lovely. Thank you very much. Thank you. So thank you, everybody. Thank you very much for all your questions. As we've mentioned before, we've recorded this evening's session so we can make sure we can share it with all of our colleagues and wider across the Trust. If anybody has got a specific question that they'd like to ask myself or Zoe in the future, there's a page on our website called Get in Touch, and there's a button there you can click, which takes us through to the board where you can ask us any questions you want, and we'll get back in touch with you. So thank you, Deirdre. Thank you, Catherine, for this evening. We really appreciate your time. Thank you, Zoe. And also thanks to Gay and Isabel, who've been keeping us in check behind the scenes.
Thank you.
Thanks very much, everybody. Really pleased you could join us, and take care. Bye-bye.